And now we have a few vignettes dealing with retention and incontinence. Let's begin with vignette number 22. A 60-year-old man shows up in the ER because he has not been able to void for the past 12 hours. He wants to, but cannot. On physical examination, his bladder is palpable, halfway up between the pubis and the umbilicus, and he has a big, boggy prostate gland without nodules. He gives a history that for several years now he's been getting up 4 or 5 times a night to urinate. Because of a cold, 2 days ago he began taking antihistaminics, using nasal drops, and drinking plenty of fluids. This is a classic case. We see this very common. This is acute urinary retention with an underlying issue of benign prostatic hypertrophy. So this man, because of his age, already has a big prostatic gland. He already suffers from the need to urinate during the night. But then the precipitating event for the acute situation now was that cold that he had. He takes antihistaminics. Antihistaminics do not help the bladder empty. But worse yet, nasal drops to dry out his nose. The active ingredient of those nasal drops is alpha drugs. The innervation that closes the bladder neck is alpha. In fact, we nowadays treat most patients with BPH with alpha blockers. This man gave himself a big dose of alpha, so he cannot empty the bladder. And because he's been taking plenty of fluids on account of a cold, the bladder is full and it's got no fluid, has no place to go, and he's very uncomfortable. Well, we can take care of his problem by catheterizing him. And that's what will be done in the emergency room. He will have a catheter put in, the bladder will be empty. Now the further workup then will be directed at what's happening to his emptying of the bladder. The rectal exam obviously is done, and in fact it was done already on this man. But there isn't necessarily a direct correlation between the outside size of the prostate felt on a rectal exam and what's happening in the lumen itself. A post-void residual test is one of the things that would help us decide what to do next. This can be done nowadays in a technologically advanced way that is less embarrassing and bothersome to the patient. It used to be that a patient like this was asked to go void and then brought back. He would lie down on an examining table and a catheter would have to be placed into his bladder to see how much urine was there still in the bladder. But nowadays a sonogram can give us that information. So the man is asked to go empty the bladder, he comes back, a sonogram probe is run over his suprapubic area, and that machine will tell us exactly he's got 5 cc's or 10 or 12. And then the therapy relies primarily on alpha blockers. We rarely, very rarely nowadays do the transurethral resection of a prostate. That was an extremely common operation, 10 or 20 years ago. Let's move to vignette number 23. On the second post-operative day, after surgery for repair of bilateral inguinal hernias, the patient reports that he cannot hold his urine. Further questioning reveals that every few minutes, he urinates a few milliliters of urine. On physical examination, there is a large palpable mass arising from the pelvis and reaching almost to the umbilicus. This is acute urinary retention with overflowing continence. Remember when we talked about post-op care? We pointed out that every time we operate in the lower abdomen, the inguinal area, around the rectum, that is common for the bladder not to be able to empty. And that is why we typically write in our post-op orders, call me if the patient hasn't voided in 6 hours, and one then helps a patient void or puts a catheter if needed. But if that isn't done, and that bladder just fills up and fills up and fills up, It reaches a point when the hydrostatic pressure on the bladder is so high that it overcomes the pressure of the sphincter and urine comes out. When that happens, the patient has no control over that event. The patient cannot stop that urination from occurring. And so interestingly enough, the patient's perception of the problem is not, doctor, I cannot empty my bladder. His perception is, doctor, I cannot stop this urination. But actually, only a few cc's of urine come out, because as soon as you lose a little bit of that volume in the bladder, the balance of pressures goes the other way, only to change again in 10 minutes or 15. And that's why you have this history that every 10 or 15 minutes, he has a little bit of urine that comes out over which he has no control. Obviously, what he needs is a catheter that will empty the bladder. Given the over-distension that has taken place, that catheter will have to be there for several days. And then this should no longer be a problem, because this is a post-operative event. Let's move now to vignette number 24. A 42-year-old woman consults you for urinary incontinence. She is the mother of 5 children, and I might add, all vaginal deliveries. And ever since the birth of the last one, 7 years ago, she leaks a small amount of urine whenever she sneezes, laughs, gets out of a chair, or lifts any heavy objects. She relates that she can hold her urine all through the night without any leaking whatsoever. A classical example of stress incontinence. We have referred repeatedly throughout the course of this review that women have a very short urethra. We mentioned that apropos of the fact that it very seldom is injured with pelvic fractures. We mentioned that apropos of the fact that bacteria can get up into the bladder quite easily. And yet, even with that very short urethra, a normal woman does not have stress incontinence, because both her urinary bladder and her sphincter and urethra are within the same high pressure zone of the abdomen. When a normal woman sneezes or coughs or strains, the same pressure that is applied to the bladder is applied to the bladder neck. Urine doesn't come out. But then the lady has 5 babies, all of them vaginal deliveries, and she destroys her pelvic floor. Now the neck of the bladder and the urethra are in the vagina, outside of this high pressure zone of the abdomen. When she laughs or sneezes, pressure is applied to the bladder, but not to the bladder, neck, and the sphincter and the urethra, and the urine comes out. Stress incontinence. If this is early and the physical findings are not impressive, this lady can be taught to do the exercises that strengthen the pelvic muscles, Kegel exercises. But if on physical exam she already has a big cyst to seal, then a surgical repair will be required.